a reminder to record. Okay, so you should be seeing a screen that is telling you that this session is being recorded, as are all sessions during UC GIS week. And I will we can look at questions in the chat. Amy will help moderate the chat, and you'll be on mute for the duration of this presentation. So our first speaker, before that, I have a few housekeeping and welcome notes to go over. So the first speaker will actually start at 11:10, and I want to take a few minutes now just to welcome you again to UC GIS Week. UC GIS Week, this is the second time we're doing it. It's a collaboration among the 10 UC campuses, and we're a group of volunteers that have put this together. Faculty, librarians, GIS analysts throughout the campuses. We've all worked over the last several months to put this program together for you. So we're super excited that you've come here to the first session. It's always a stress, right? How many people are going to show up? And I see we have 31 besides Amy and I, so I'm just thrilled beyond words to have you here. So again, it's an event that brings us all together among the campuses for opportunities to learn from each other, network, create new contacts that we can reach out to. There are a lot of people with similar interest among the campuses, and this is a way to facilitate that networking among the campuses. So how do you get involved, and how do you then be able to reach out? We have a Slack channel that runs during UC GIS week as well as the other 51 weeks of the year. So Amy, correct me if I'm wrong, but I think the QR code is the Slack channel. Is that right?
The QR code is actually the event survey that we're asking everyone to fill out post, but I'll repost the Slack space in the chat box for everyone.
Perfect. Okay, so we do have the Slack channel, and you're welcome to join that. That runs all year long. And that's a way to stay engaged with the UC GIS collective. So again, the main focus of UC GIS collective here is this UC GIS week. And that's what we're doing now. Amy just posted the Slack channel. You're welcome to join. You're welcome to comment. You're also welcome to tweet out your impressions of this week. If there's lots of tweets out there, and that'll help us have even more people for the remaining sessions. You can use that hashtag UCGISweek. Which you see in the lower left of the screen that's up right now. So let me ask, are there any questions or issues? We have about 5 more minutes. I want to really keep on time, so we'll start the first session at 11:10, which is just 4 minutes from here. But Amy, are there any questions in the chat that we should deal with?
Nope.
Okay. In that case, let me give you a few highlights for the coming days. As you know, this is track 1. The first public health session will be really focused on COVID-19, which I'm sure everyone that's come is very much interested and vested in. So here we are to talk about something that's been on our minds for almost 2 years now. Amazing. But we have more public health sessions. You know, we're running 2 simultaneous sessions, and if you're not able to go to every session, they are recorded. So you're welcome with your registration to log back in and see the sessions that you missed. But we do have additional public health sessions from 1 to 2 p.m. today. We have Eva Raphael from UCSF going to talk about some drug-resistant some microbial resistant bacterial research that she's been doing at UCSF. we have one of my students, actually, Ali Zermeno from Berkeley, to talk about ethics with GIS, the ethical considerations of the use, collection, reporting of GIS, really focused on the locus charter that some of you may be aware of. And Yanning Mao, a student at Riverside, which will focus on pollution modeling. So that's just a quick glimpse at what's coming in Public Health Session 2, 1 o'clock to 2 o'clock. There's also lunch networking session set up today. You can find the Zoom links in your registration. And I should mention, to make it clear, every session has its own Zoom link. So don't stay here. This session will be closing at noon. And there'll be, for whatever sessions you want to go to, there will be different Zoom links. So I think 10 minutes might have been a little long for the welcoming, but I do want to keep time because I can see people are just coming now, not to hear me give welcome comments, but to hear Eric Williamson talk. So Eric, sorry, but I'm going to hold off until 11:10 because I think at 11:10 we'll get a surge of people who are coming to hear you talk and not me. So
well, we can hope.
I appreciate your patience. I think next year we will make welcome a little shorter. So given that, I have a question that if everyone could put in the chat, whether for timing for next year. Last year we had an hour between the 1 o'clock or after the 1 o'clock session. We went 1 to 2 and then 3 to 4. Put a +1 if you think it's better to have an hour, so a free hour between 2 and 3, and a session then goes from 1 to 2. There's a free hour, and then the next session goes 3 to 4. Wait, 1 to 2, blank, 3 to 4. Put a +1 if you think that's better, or a 0 if you think it's better to go 1 to 3 straight through. Into the chat, a +1 for having that hour break from 2 to 3. Lots of people thinking it's better to have a break. Okay, while you're doing that, we're good to go. It's 11:10 exactly. So it's a great pleasure to introduce, excuse me, Eric, I have to have my cheat sheet here. Eric Williamson from UC San Diego, Eric is a data manager for the strategy office at UC San Diego Health. He has worked with data sets for 25 years and recently began incorporating GIS into his data analytics skills. Eric, please share your screen, and we look forward to the presentation.
Thank you. Okay, I'll share my screen. Now let me close a couple items on here. Go. Okay.
Perfect.
Thank you for the introduction. I'm assuming everyone can see my screen.
Yes.
So, Amy, actually, if you can do me a favor and post the link into the chat so people have it later, that would be nice as well. I'm going to talk about geocoding and how we use geocoding to assist with the vaccine rollout. Specifically, we used StreetMap Premium and SQL Server to prioritize which patients would be receiving the vaccine during our rollout. So let me start with a little bit of a preamble. This is in ArcGIS story maps, by the way, so this will be publicly available. Back in March of 2020, Governor Gavin Newsom determined that we needed to reserve 40% of the vaccines for the neediest portion of our population. And what that meant is that we noticed that people who lived in the lowest quartile of our California census tracts were disproportionately being affected by COVID. So in order to combat that, we wanted, when the vaccine was being rolled out, we wanted to prioritize those people from those census tracts. Now, these census tracts were identified by the California Healthy Places Index. I have the website up here. This is actually a pretty good website. It's a bit of a segue. If you're just interested in geocoding in general, you can do a lot with this particular website as far as clicking on here, and it gives you information about the different tracks as far as social indicators, environment, and they have race and ethnicity listed in here as well. And then when you click from one track to another, all the data changes. So I could spend hours just working on this. But the big takeaway from Healthy Places Index for us was that they keep a list of the census tracts in quartiles. So from the top 25% down to the bottom. Let me go back. So you can see it's right here. You've got anything in dark blue was considered in the bottom quartile. And therefore, we wanted to prioritize getting patients in those census tracts the shots first, the vaccinations first. So one of the benefits that the HPI website gave us is that they do publish the data, and they have it in an Excel file, and as well as the CSV version. So I was able to take that information and I was able to download it into a SQL Server database. I also have patient addresses in this same SQL Server database. So anybody who's working with health, we use Epic as our electronic management record for electronic medical record for our patients. And so we were able to pull the address information for our patients as well. However, we don't have the actual census tract information as to where those patients are located. So that's not anything that is contained in our data. And therefore, we had a bit of a quandary. There was a gap between the address and the census tract that I needed to bridge. What that meant is that we had the address, but I couldn't, with the address by itself, I couldn't tell which census tract they belonged to. And therefore, without the census tract, I couldn't assign the patients to the correct HPI score. The way I was able to bridge this was using ArcGIS StreetMap Premium in conjunction with SQL Server. So ArcGIS StreetMap is an add-on that can be installed with your ArcGIS Pro desktop software. And I'll make an assumption that most people are familiar with ArcGIS Pro. Specifically, one of the features with StreetMap Premium is the ability to convert an address into latitude and longitude coordinate that you can then plot on a particular map. Okay, so here is a screen capture of ArcGIS Pro. And if you see here on the far right, this is the add-on. It's the geocoding address. And what I'm doing here is I'm capturing information that I inserted into the desktop app from my SQL Server, pulling from the tables. It then does the geocoding and then puts the output into another table file that I'm then able to upload into ArcGIS. And if you look at the screen here in the middle, you can see that this is sample data of all the points that have been plotted for our patients. And as you can see, even though it's UC San Diego, we do cover a wide swath of patients as far as their locations. So now that I've taken this information, I was able to geocode it and insert it into a SQL Server on the table. After that, it was a process of me doing a series of joins using the built-in SQL logic in order to build out the connections between address and census tract. So Forgive me if I know this is ArcGIS and not very many people are familiar with SQL, but let me see if I can do a brief explanation. So this is in the upper left, the query that you can write against the table to pull information out. And these are the results that are being displayed. These are individual columns, if you will. And one of the nice things about inserting the geocoded history is that SQL Server can manage spatial data. So this S2 column right here, this is the actual representation of the plotted points. And if you click on another tab within SQL Server Management Studio, it will show you the actual points. And you can kind of make out this, looks a little bit like California. So this is the geocoded data for our patients. Sorry, give me just one second. Once I was able to insert this information into SQL Server, I was then also able to combine it with an imported census tract shapefile that I had also imported into SQL Server. And you can see this contains all the census tracts for San Diego County. So what I was able to do then with this is I was able to combine the two tables together. I had the geocoded history and then the census tract information. And I used some code that's contained within SQL Server calling, it's an ST contains, it's a method that allows you to display points that occur within a certain, not a point, but a certain polygon. And so the census tracts were polygon shaped, as you can see. And then we were basically identifying which points were contained within those polygons. And the results of that were I have my patient ID here. You can see the address type that was determined by the street map. But more importantly, I was then able to combine those 2 points together to determine the census tract ID for those individual patients. So each patient was now assigned to a census tract. Now then, once I had the census tract, then it was really a simple matter of then connecting the census tract number to the HPI master file. So I downloaded the information that HPI had on its website into a third table. I then combined that together. And then what we got as a result, as you can see, we had the patient ID, we had the census tract they belonged to, but then we were also able to add on their HPI scores, the quartile they belong to, and then HPI made it easy for us. They actually have a column that shows us which census tracts are considered to be in the lowest 25% as far as the Healthy Places Index goes. So you can see this patient here would have received priority on getting the vaccine, as with this patient and this patient here. So the takeaway was that with the help of using ArcGIS in SQL Server, UCSD Health, we were able to prioritize over 500,000 vaccinations for our patients within San Diego County in a 6-month period. Now, for additional context, if anybody wants to read up on how to do some of this information, I've included some of the links, including like information on using SQL Server, where you can get Street Map Premium, as well as the Healthy Places Index, the LA Times article that talked about the need for doing this, as well as some California documentation on a blueprint for a safer economy. So that is the conclusion of my presentation. I'm happy to open it up for any questions.
That was fantastic, Eric. And I'm teaching applied GIS for public health at Berkeley. I'm going to make this presentation required viewing for my class. You had a lot of great information here. I'm seeing in the chat some positive comments already for your presentation. So for the guests, for the attendees, pardon me here, I didn't notice any questions in the chat, so feel free to scroll your mouse down and you'll see the reaction icon, which has a smiley face with a plus. Go ahead and click on that, and then you can raise your hand if you'd prefer, rather than writing a question in the chat, just to speak up and ask a question as we would if we were live and in person. You would go up to the microphone and ask the speaker the question. So let me throw that out. I'm not seeing any hands yet. Amy, you have your hand up. Go ahead, please.
I do. It's a great presentation, Eric. I always enjoy hearing sort of more about how you used all of this. And I'm thinking, based on sort of your analysis of this and sort of allocating the vaccines in the areas that needed to be done, how has that changed sort of UC San Diego Health's perspective on perhaps other things, or utilizing GIS to maybe investigate other?
That's a great question. So the Healthy Places Index, in this particular instance, we were focused on the bottom quartiles, but we are now geocoding all of our patients going forward. So we always know what census tract and what Healthy Places Index census tract they belong to. And therefore we can now go in and look at other metrics that are related, like air quality, for example. So if you have a patient who has asthma, you can, now our physicians can, at a pretty quick glance, look and see, well, where do they reside? You know, what's the air quality out there? You know, is the ozone a lot higher and in the inland valleys, which it is, than it is out on the coast, and could that be having an effect on a particular patient? Or other things that Healthy Places Index talks about is, you know, what's the tree canopy like? How close are they to public transportation? How close are they to public parks? So a lot of these are indicators of health that can be applied for a physician to help with taking care of their patients. So if you know that somebody needs to go out and get exercise, but they don't live close to a park, which is something HPI can tell you, then that might be an indicator that you need to find other ways of helping that patient get more exercise, or that could be an inhibitor. So the consequences of using HPI and geocoding are huge for healthcare, absolutely.
Fantastic. We have a question from Debbie O. Eric. She's asking, do you know if this prioritization has led to reduced disparities in COVID cases?
I would like to say yes. I did run the numbers briefly. I have to say we didn't have as many out of the 500,000 that we did. There were about 50,000 that came from the bottom quartiles. Now, I don't know if that means that just San Diego doesn't have as many people, or if the people in the lower quartiles weren't coming out for the vaccines, even though they're prioritized. But the option was definitely made available to them. And we are reaching out in many other ways to try and manage the disparity that we currently have.
Great. We have a question from Carlos Barona, who's also a member of the UC GIS Week team that has put this all together. Carlos is asking, I'm curious how much of this was already in place prior to COVID-19. Did you already utilize StreetMaps Premium? Were you already making use of spatial data in treatment planning in any way? Or was this a brand new initiative, Eric?
This was mostly a brand new initiative. I know Amy did provide us with the geospatial, or the StreetMap Premium software before COVID, but we hadn't really thought about applying it on anything like a large scale, such as mapping all of our patients in this way. It was when COVID hit, and then we became aware of the Healthy Places Index, that we did combine the two together. in order to build out the data sets that you saw. So it was really, I mean, we did have all the pieces. It was just kind of combining them all together. That was the step that COVID really implemented for us.
Fantastic. So there's actually a few comments in the chat that are going to be helpful for the attendees at this presentation. Mano Simone has put up a chat posting that I think with a link that I would welcome the attendees to take a look at. There are many people attending here from the UC campuses, and the leadership committee, Mano is saying, is expecting 6 or 7 campuses to have licensing for StreetMap Premium by February 2022. So there'll be opportunities for additional people to look back at Eric's presentation and see if they could do something similar, either with the social vulnerability indices that he used, or a lot of people are using Cal and VirusScreen for, as Eric pointed out, drawing links to pollutants and health aspects. So there's a number of vulnerability indices available, but we can sort of use your methodology, Eric, with other social vulnerability or health indices to ask some of these important questions about relating health to the environment or to certain conditions within a place or space. So with that, Eric, I'll thank you very much for an excellent presentation.
Thank you. Amy, if you could post the story map one more time for people who came in late.
Right, she just did. So I welcome the attendees to look back at Amy Work's post. It's 3 up from the bottom, and you'll see the post for Eric's story map, which is made publicly available. And I think you just posted again. Yeah, so there it is again. It'll be the very last post in the list. And please take a look at that. You could see a lot of great interactivity with Eric's story map. So don't just scroll through, spend a little time poking around there. Thank you again, Eric. I'll ask you to do a stop share now so that our next speaker can go ahead and share her screen. So our next speaker is Diana Henderson at UC San Diego as well. I see, Diana, your screen is shared perfectly now.
Awesome.
Years ago, after being hired at UC San Diego as a Facility Space Analyst, Diana Henderson was asked to stand up a campus GIS program. Accepting that challenge vaulted her back from a 15-year hiatus from GIS, and Return to Learn project has manifested as the lightning in the bottle, demonstrating GIS viability and garnering executive support for the burgeoning and critical operational technologies. So thank you, Diana. Please feel free to start.
Awesome. Thank you, Charlotte. And thank you, everybody, for showing up today. So I'm going to condense as quickly as possible this presentation. I've done this a few times, and so I've got a few slides here. As Charlotte mentioned with my bio, I had taken a break from GIS, not because I didn't think it wasn't the best tool out there. I was at a point where justifying GIS was kind of at the end of my rope. And 2.5 years ago, when I started at UC San Diego, I was asked to stand up a GIS program, which meant for the last 2.5 years, I've been justifying GIS. So it's been challenging. And this project has also helped to demonstrate that GIS is certainly a critical modern technology that a campus of UC San Diego size should have. And let's just get into the project. So we started a project where we're actually tracing COVID-19 through effluents. And it's a part of the Return to Learn program to get students back on campus and get students back on campus safely by providing automated trace analysis and visualization so that our notification systems work effectively. So the Return to Learn program began in May 2020 as a strategic response to COVID-19 pandemic. Return to Learn leaders understood early on that the high volume of wastewater samplers intended roughly 150 to 200. We're not at 200 yet, we're getting there. The frequency of collection daily prescribed a scalability that we couldn't achieve with manual processes. The pillars that we're addressing with Return to Learn with GIS include viral detection and intervention. And we are the connectivity of geospatial layers with the wastewater elements, timely and accurate tracing, targeted notification. With all of these combined characteristics, we increased individual testing rates 13-fold and enabled detection of 85% of COVID-19 cases. So I was tapped in June of 2020, and just to give you a sense of the construct of the team, we've got people on the administrative side, Operations Strategic Initiatives, project managed the project, H&S helped with regulations with the sewer, stormwater, campus planning, which I was a part of, and geographic information systems, logistics, ITS, facilities management, HGH, all were involved in this project, which then we were also collaborating with the academic side, the night lab, epidemiology, medicine, biochemistry lab, all of them had a great deal to do with how the lab results were obtained and what type of tests were administered. Amy Work is on the call with the library, helped us to understand the licensing structure for our different research student, and anybody on an academic side was able to get a license through Amy's efforts. So early on, we actually built a workflow that did not and has not changed much from our initial outline. And so if you start down at the left-hand corner, you see a manhole, there's an auto tester. It kind of looks like a little robot that they actually add to the manhole, which has a lanyard that is tied to a receptacle that when you push a button, the effluent comes up in the container, which is then pulled by the field worker, and they scan the barcode device on that container and the auto tester to correlate that to the manhole, which is being tested, and the effluent is then transported to the lab. The lab then takes the lab results and compiles them in a way that we are able to then push information back and correlate it to buildings where any instance of a positive result triggers a trace analysis, which the buildings are then correlated to a notification system, which will then provide out information, targeted information to groups either residing or working in that building. And then we can run separate analyses. Like I say, the field work maps are drawn from AGO, and we've got, like, so for instance, if an auto tester in a manhole is clogged, we've got different mechanisms that allow us to be able to understand like what may be going wrong at those auto testers so that we can rectify any issues that may be occurring. So like I say, this was at the beginning, hasn't changed much, it just has changed a little bit. And unfortunately, we in initial glances at the data, we came across some very real issues. One of them being that, unfortunately, I don't think the engineers understood that when you have sewer pipes and manholes, and you're drawing them in electronic fashion, you should be emulating the real world, which means, in the case from the picture on the left, that the pipe should actually be connected to the manhole. Now, it's a little bit hard to see that the dot there is actually representative of the manhole, and the lines you see are the pipes. But you can see that, unfortunately, the pipe does not connect to the manhole here. And this was a predominant feature of the layer system that had been created. So my recommendation was to fix the data, and that was not done initially, unfortunately. The other thing that had occurred was that rather than understanding gravity fed and aligning the pipe line directions with the gravity flow, they actually created a whole new object layer with points on it that they would then rotate any arrow to reflect the line, which would be inherent in GIS if you had the line drawn in the correct direction. So rather than fix the data initially, they created an Excel table that had really nothing to do with a relational database, which I then had to create into a crosswalk table that allowed us to correlate the manhole, the manhole first in the downstream from a building, so we could correlate between that building and the manhole that it was connected to. So that essentially created over 400 hours worth of work to really as a workaround that essentially didn't solve the problem, because what ended up happening is because it was that converted that Excel into an Access, which is still disconnected to GIS, which meant that one of the researchers had to take 2 to 3 hours a day out of their busy schedule, which they should have been doing other things, doing trace analysis for 4 months. As you can imagine, that person was not happy to have that happen. So eventually the data was fixed. And so what we learned was that we need to really understand how to coordinate more effectively across multifunctional teams, reducing redundant efforts and miscommunication. One of my big jobs was providing really the community with better education concerning the GIS capabilities. You know, there hasn't been a GIS program on campus ever. And so there really is kind of a dearth of understanding about its capability. We also modernized the workflow and data linkages between the field workers and analysts, so that again, we have this information in the cloud that everyone has access to. And we automated manual tasks so that we could recoup time for people so that they could work on other things, as well as reduce the potential for error and omission. So just to get into a little bit of the nuts and bolts of what we have, this picture is showing a little bit about the fieldwork side, which is, as you can see, is a little bit bigger picture of the auto tester. The middle frame is the survey that we created in ArcGIS survey 123, connected to Arc Explorer, which of course is going away at the end of this year. So field maps, everybody get on field maps. And the ArcGIS online application, which was created for the superintendent to actually go through and create zones or routes that then the field workers would go out and take samples from the specific auto testers in their route. This actually, so I'm gonna try and describe this as best as I can. This was actually created by one of those researchers and students, and it actually helped to automate. Again, there was some manual efforts being performed with the lab results that a couple of people actually automated, so that they could then take the lab results from a lab plate and take that information, consume it, and convert it into a consumable format into a Google Sheets that we could then upload into the ArcGIS API. So essentially it's calling to see if there's been any changes to the Google map, and then it updates the cells. Which then that information that it updates then gets sent into the tracing algorithm, and that trace result is then called by the API to update the layer. And we then are provided with a dashboard back of information, not only a dashboard again, but one of the key things was notification out to where we knew students would reside. We had a list of that. We had a list of a pretty comprehensive list of where people were working, and then also public notification. So here is the dashboard that was ultimately created as a solution. So it's showing, of course, in the red where there were actual positive COVID samples acquired. And you can see on the far right that we actually were able to do a temporal map of over time, like how many samples or positive samples were obtained from certain sites. And so that people could go back and look at the history of what was going on there. So that, in a nutshell, is the project. And Charlotte, hopefully I'm on time and not over or maybe under.
You're just, I wouldn't say under or over, you're perfect, leaving
Perfect.
a few minutes for questions here. I didn't see any questions in the chat, but perhaps any of the attendees would like to, again, scroll down to the bottom where you see reactions and just click raise hand, and we can call on you to ask your question orally. We have about 5 minutes before the next presentation, but Diana, I really admire and applaud you for sharing the lessons learned about the inefficiencies of siloed organizations, because we all have that at every campus and every institution. There's silos which create kind of some inefficiencies and wasted time doing work that what your presentation, I think, really brought together is the value in communicating and sharing resources, communicating about needs and solutions within an organization. So it's awesome that you gave such an interesting, case that we can all kind of relate to. Excuse me, how important that is.
Yeah, like I said, that was an interesting journey, and a lot of it helped me to understand that a lot of what I was going to have to do over certainly the first part of that project was education, because of that lack of GIS, university GIS knowledge. There really weren't a lot of people who understood that by using this tool, we could become more efficient and save people a lot of time and get accurate results. So that was certainly a big lesson learned for me.
Right, and I bet there's people there at San Diego that don't even know Amy work and wish that they did, because you have great resources at San Diego and a lot of interest in sharing and collaborating.
Absolutely.
No.
We have talked about too, I just wanted to mention that we are trying to make this project distributable and provide. We've actually talked to a few other universities and talked about like what we did, and I know that there has been some communication out from the marketing team / return to learn team to other universities about.
That's great, and that's certainly one of the goals of the UC GIS Week collaborative and the UC GIS, among the 10 campuses, really to help facilitate those kinds of interactions. At Berkeley, we have a new person, Mayana Bogue, in our facilities department. I bet she would be interested, but again, she's very new, so she wouldn't know. And so, again, at UC GIS, we're trying to help facilitate some of those interactions and introductions. So Sabine, said, just joined, sadly, I got the time difference wrong, just realized chance of catching up on these presentations. Yeah, the good point, Sabine, so I can announce again that all of the presentations are recorded and you're welcome to look with your registration later through the UC GIS week. Amy, can you help me out for looking at the recordings after this week? How is that done, Amy?
Yeah, I would say you can register and we'll send out an email through the registration link, as well as follow up on the agenda and on the website. And so I'll
On the
place those
website.
links.
Okay, right. So the website's always a good place to find everything. I should have thought of that. So, yeah. So, and then it sounds like a follow-up email as well will go to all attendees. I think everyone who's here has registered, and I see that one of the other team members of UCGS Week, Carlos Barona, has put in the chat the hub for UCGS. So go ahead and copy that link that Carlos just put up and save that on one of your little sticky things, or make a new Word or notes document, however you save these things for when you'll need them later on. So yeah, that's anything else? Any questions from any of the attendees for Diana, or if there's any remaining questions for our prior speaker, Eric Williamson from UC San Diego? We have just 1 or 2 minutes here before our next speaker. We're trying to keep time so that people can jump back and forth between track 1 and track 2. And the happy news is we're virtual. You don't have to run out of one room. Oh, there is a question. Aswara, could you take yourself off mute and ask your question, please?
Yes, thank you. Hi, Diana. That's a great presentation. I have a question. So the return to learn that you showed, the dashboard, it looks like it's on a Tableau platform. So can you discuss a little bit of about it and how that helped you in data projection, like, sharing with the public?
So I can give you a little bit that portion. So I was involved from May. I'm still involved on an ancillary level but I was heavily involved from May to December, and then a researcher and a student took over, and they were the ones who built the automation between the spreadsheet and the tracing tool, and then connected the dashboard. So we worked closely with ITS, who that map you saw was a small portion of the dashboard that ITS created. So and ITS created that in Tableau, and then we embedded the ArcGIS map into that Tableau body. And so I don't have a lot of intricate details about that, but if you did want to learn more about any of that connection, certainly reach out, and I can get you more information.
Thank you.
Thank you so much. So we'll go ahead with our next speaker now, Dan Meltzer, Dan Meltzer from UC San Francisco. Dan is a GIS analyst with the Dream Lab at UCSF. You can find that website at dreamlab.ucsf.edu. Dan is in the Department of Epidemiology and Biostatistics at UCSF. He's interested, as we all are, in better understanding how space and place influence health disparities. Dan, go ahead and share your screen, please.
All right. Thank you, Charlotte. And hi, everyone. So today I want to talk about geographically weighted regression using data about COVID-19 and neighborhood factors in California. So I'm going to first, oops, there we go. First mention a little bit of background. So we know, of course, that racism of all kinds, structural or institutionalized, personally mediated or internalized, deeply impacts all aspects of health. And you know, for beginning background on this in public health, you can check out Dr. Kamara Jones's work. And there's plenty of other work on this. And we know that the disparities across race, ethnicity have been documented also across COVID-19 diagnoses and outcomes. One way that structural racism impacts health outcomes is via neighborhood factors, such as, you know, like the amount of people that have health insurance in an area. The purpose of this study was to better understand neighborhood level factors that drive disparities in COVID cases by race, ethnicity. And our goals here were to use census tract level data to examine how neighborhood level factors are associated with COVID-19 cases, to identify the factors most influential on disparities for Hispanic, Latinx, Black, African American, and Asian American populations, and then to identify regional differences in these factors. So for data, we used all COVID-19 cases reported through January 31st, 2021 to California Department of Public Health, CDPH. And for that was for COVID data. And then for neighborhood data, we used American Community Survey, census data, and HUD data for 8,009 census tracts in California. So for these variables, for example, you know, the percent limited English proficiency within a census tract, or the percent uninsured in a census tract, etc. And just to give you a sense of what the case data looks like for California for our data set that we were using, this is quintiles of cases per population. So you can see in the dark blue is where the highest number of cases per population were of COVID in the data set that we had from CDPH. And as a side note, I also just wanted to mention another of our projects that you can access right now online at healthatlas.ucsf.edu is Health Atlas. And here we have a lot of variables available for browsing. You can look at them together and separate. And a lot of these variables are the ones that we used in this study. So a lot of the data is available here. I encourage everyone to check it out if you get a chance, healthatlas.ucsf.edu. So back to this particular study, we used quasi-Poisson generalized linear models first, then we did sequential models for Hispanic, Latinx, Black, African American, and Asian American population groups. And then we did sub-analyses on census tracts with those populations. And then we did a geographically weighted regression. So I'm going to focus on the GWR, but just to give you a sense quickly of the non-spatial model, we showed that neighborhood level factors contribute to COVID-19 disparities across race and ethnicity, not surprisingly. And in our sequential, just to give you one taste of what we did non-spatially, we did some sequential models. And basically what this means is that we took the race ethnicity variables, added in each of the other variables one at a time to see what would be the most, what would have the most effect on the outcome. And then we did a sequential model where we cumulatively added those variables in the order of importance from that one at a time version. So basically what you're seeing here is that the effect of the race ethnicity category variable on the outcome of COVID cases went down dramatically with when you add in the variable for limited English proficiency, at least for Hispanic, Latinx, and Asian American groups. And so that seems to be an important variable for explaining some of the disparities, as you can see here. So in the GWR, the geographically weighted regression, we included all the variables in the model and excluded 26 census tracts with population of 0. And GWR, basically what it does is we're doing a regression that centers on a central census tract surrounded by, and the census tracts around it, immediately around it, using an optimized bandwidth. And then doing that over and over for all census tracts in California. So what you come away with is the effect, the importance of each of the variables in the overall model by region, by area. So we use the SPGWR package in R to calculate optimized bandwidth and run a log-link quasi-Poisson GWR model. And since limited English proficiency had seemed very important in the non-spatial model, we looked at that in particular when looking at the results of the GWR, and found that it was highest in the urban and suburban areas of the Bay Area, LA, and San Diego. So that's what you see here. This is the coefficient for limited English proficiency for that geographically weighted regression. In the dark, it actually looks like purple here. It was blue in another version. But in the dark purple, you have the highest coefficient for limited English proficiency. And you can see in these zoomed in maps of the Bay Area, Los Angeles area, Sacramento area, San Diego, and Imperial counties, you can see where that coefficient for limited English proficiency has the highest effect on the outcome of COVID cases. And so we concluded that, not surprisingly, neighborhood level contextual drivers of COVID-19 burden differ across race ethnicity groups, and that the effect of these neighborhood level factors differ by region in California. And I just wanted to mention, these are all the authors that have been involved in this project, and we have a paper under review currently. So with that, I'll open it to questions. Thanks.
We have time for maybe one question, if there is one. I don't see any in the chat, Dan, but I first met Dan when he was a founding member of Mapping for Social Justice, and we can see that your passion for that has remained, Dan, so this is fantastic. Your presentation and certainly the paper will be required viewing and required reading for my public health class. And can you go ahead and stop share, and we'll go ahead with our next speaker. Yeah, lots of compliments. And Amy put up the healthatlas.ucsf.edu in the chat. And I know the presenters here are going to be excited to look at that. Dan, thank you for an excellent presentation. Our next presentation presenter is Caitlyn Jeri Linehan at UC Santa Barbara. Caitlyn's a PhD student within the Geography department at UCSB. And I see your slide there perfectly. Caitlyn, go ahead, please.
Hi, Charlotte. Thank you. So hi, everyone. As Charlotte mentioned, my name is Caitlyn Linehan, and I'm a graduate student at the University of California, Santa Barbara. Today, I'll be presenting on a really unique topic. I'm going to be looking at patterns in COVID-19 trends in people giving birth. So as everyone's pretty familiar in this group, there are really two big issues that come with COVID testing, and that's going to be the early detection of COVID, as well as detecting asymptomatic cases. So for this project, me and my advisor worked with doctors and nurses at 2 hospitals in Arizona. And we worked with these doctors to explore these challenges. And how we did that was these doctors were able to test for COVID in people who are coming in to give birth uniformly. I would like to mention this is a pilot study, so we're still receiving data. So this is a work in progress. But working on this project, we really wanted to see if people reporting for labor and delivery could show evidence of community spread of COVID-19. So that was exploring both spatial and temporal trends. And then we also wanted to look at the socioeconomic differences between two different groups of people from these two different medical centers and explore their demographics and the spatial trends of the positive cases. The first medical center that we worked with was Honor Health Medical Center. We tested 3,965 patients, about 3% tested positive and 97% tested negative. And then Reality-Wise Medical Center, of which we had 1,354 patients, 5% tested positive and 95% tested negative. So this is some demographic data. This is a timeline of when we tested patients. So we tested from April of 2020 to March of 2021, but our complete data set lies within May of 2020 to February of 2021. On these outlier dates, we only have data from one or the other hospital. Oh, sorry. So this is some race and ethnicity data of our patients that we tested. And from here, we can see that the Valley-Wise Health Medical Center, the majority of patients identified as Hispanic or Latinx or Black or African American, while in Honor Health, the majority of our patients were identified as white or Caucasian, followed by Hispanic or Latinx. As far as language spoken at home, we can see for Valley-Wise, it was pretty split between patients, and for Honor Health, the majority of patients spoke English. As far as income went, we were able to have the zip code, what zip code each patient identified in. And what I was able to do with that is aggregate up some census tract data to get some insight into what the average median income for our patients that were coming from Honor Health and Valley-Wise of the zip code that they resided in. And from this, we can see that the majority of our patients from Honor Health were coming from in a higher economic income bracket, while Valley-Wise, the majority of patients were coming from zip codes with a lower income bracket. So our final temporal trend that we're going to look at is we have this chart shows the percentage of positive cases from May of 2020 to March of 2021. And the left x-axis shows the percentage of cases that tested positive for all of Arizona, while the right orange axis shows the percentage of cases that tested positive just for our medical centers, Valley-Wise and Honor Health. And with our Arizona statewide data, we can see two clear peaks of when cases that tested positive were at a high. So the first peak occurs during the summer of 2020, and the second peak occurs at the end of 2020 and the beginning of 2021. And what we can actually see is some peaks in the medical centers as well. So we see a peak with Valley-Wise that roughly corresponds with our first Arizona statewide peak, and we see a peak in Honor Health that roughly corresponds to the second Arizona statewide peak. So as we know, COVID-19 disproportionately affects people of color and those who come from a lower income bracket. So the second peak in the Honor Health data is a little bit surprising because from what we just saw, the Honor Health patients are coming from areas whose residents have a higher income and identify as Caucasian. So why is the second peak occurring? Because this is a pilot study, we don't know for sure. But one piece of anecdotal data that can help explain that is we were working with a lot of doctors and nurses who were on the ground at these hospitals. And they said at this point in time, a lot of the patients who were coming in alluded to not social distancing and having in-person events such as baby showers that could have promoted the spread of COVID-19. So if we go to some spatial exploration, if we look at the zip codes the patients identified as living in, we see some spatial variation. So the majority of Honor patients are coming from these northeastern zip codes, while the majority of the Valley-Wise are coming from these southwestern zip codes. One interesting hotspot analysis we did had to do with this insurance data So we had the insurance data of all of our patients. And for Honor Health, we can, this is only for one medical center. And for Honor Health, we can see that the percentage of positive COVID cases was higher for the patients who had Medicaid as opposed to managed care insurance. And what I did with that was I looked at the cases per zip code, the positive cases per zip code, and I did a hotspot analysis of these positive cases by zip code, by insurance type for each of these patients. And from this analysis, we could see that the hotspots of positive cases for those patients who identified as having managed care health insurance, they had an income, an average median income that was about $18,000 greater than those who had Medicaid. Okay. So this is a pilot study, but some conclusions that we can, take from this analysis is that we need to have continued testing, because with this analysis, we are able to sample incidence of disease in the general population, as opposed to only testing for heterogeneous indications such as symptoms. So this allows us to test either asymptomatic populations or before people show symptoms in these people giving birth. And the study also is allowing us to look at two very different populations that are being affected by COVID. We're processing data that's coming in from when the Delta variant occurred. So future use of this screening can also help us understand behavioral health patterns and these second peaks. And while we continue testing, we'll be able to explore the spatial relationship and variation at the zip code level, and we'll be able to compare, as we get more data, the percentage of positive cases at the zip code level between those reporting for labor and delivery, as well as the general population. Thank you all so much for listening, and I'd love to answer any questions if you have any.
Thank you, Caitlyn. That was fantastic. Let me see if there are any questions in the chat, or if the attendees would like to scroll their mouse down, click the reactions, and then raise hand. We can call on you to ask your question by going to the mic, as we would if we were all in a big conference center. But we can sleep in our own beds when we do it this way, which is nice. That was so interesting, Caitlyn. Thank you.
Thank you.
So if there's no questions, then we'll thank the speakers again. You can also click down to the reactions and click the little hand clapping, the one in the left, and we can give a big round of applause to all of our fantastic speakers. Fantastic. So thank you again. And again, I welcome everyone to join the Slack channel. Amy, if you want to put the Slack channel up in the
Yep, I'll post it up again.
Right, and then if you could also put up the screen that has the QR code for the survey. We welcome your comments in the survey. You can put, Amy will put that QR code up on the screen momentarily. Here it comes. You'll see in the lower left, go ahead and scan that code and fill out the survey. We definitely welcome feedback. This is the second time we've done this 10 campus-wide UC GIS event, and any of your comments, I'm sure, will make the third annual even better. So I appreciate all of your attendance here. For the students, the next event from 12 to 1 is the student network event. You can meet students from the other campuses, get ideas for creating GIS clubs on your campus, or if you have, like we have at Berkeley, decal classes that are student-run classes, all kinds of things. Amy has just put up the Slack link. Feel free to join the Slack channel, which runs all year. And please consider joining the planning committee for the third annual UC GIS week in 2022. If that occurs, I'm hoping it does. So thank you, and we'll close this session now. Remember, all of the sessions have their own Zoom link. Hope to see you in Public Health 2 at 1 o'clock. Take care, everyone.
Charlotte, you want to stop recording?
I am
Awesome.
looking for that. Thank you.